Okay, good morning and welcome everybody. Today I am actually joined by someone I'm really excited about. Nick and I have been, I guess before I say that, it's Nick Rainey. Um, and Nick was actually the owner of I would say is the most influential clinical rotation that I had as a student. He owns Rainey Pain and Performance in Sierra Vista, Arizona, and the rotations there are 6 months. And I have often told anyone who knows me has heard me bring up my experience at Rainey because it was life changing. Like me and my buddy Colton, we talk about it often. We were there together. We lived together. We it was we often talk about how different our career paths would have been if we hadn't spent time with Nick and his team. So, Nick, if you'd like to introduce yourself a little bit, and then for anyone wondering, we're going to talk about low back exercises today. We're going to try to get into discussing, well, I guess you're going to have to wait to hear more about that because I don't want to take more time away from Nick. But I'll tell you in just a sec. So, Nick, why don't you tell us a little bit about yourself, and then we'll get going.
Well, thank you, Nate. I appreciate you having me on. I've listened to, I think, all the podcasts so far. And I probably have 40 or 50 that I go through. So I do appreciate this one.
Yeah, thank
And
you.
I'm glad to hear that the rotation here, a few years back was so influential. I
Hmm.
obviously put a lot of time into training, so I appreciate that. Yeah, we're here in Sierra Vista, Arizona. I like to say we're a border county, but not a border town. So if people think about border towns, it's not a classic border town. We have our primary clinic here is Rainey Pain and Performance. It's largest in the county it's become, and which is somewhat amazing because when I started, I thought it would just be me. We've also started a separate clinic that just focuses on underserved population Medicaid here. Uh, that's what I enjoy treating and teaching.
Cool. And remind me, do you guys still have the office partnered with? Oh, give me a second. I may be able to remember his name. Chiropractor, big guy, real good.
Travis Furry. Yes.
Furry, yes, Furry.
Yep. So we still have three providers over in that office. The rest of us over in our larger office, but they do all our back end stuff. It's a perfect marriage. I mean, we have a great business relationship, and we're friends as well. Not much of a clinical relationship, but
Sure. And the new one, Tony, right? Tony
yep,
Rich. He opened the Medicaid
yep,
one, and that's at a separate location.
yes, that's separate. And I try to keep those things pretty separate, not involve anybody over at our main office with that.
Oh, okay, cool. So, anyone wondering? So, Nick is a fellow, and Nick, you are a fellow in manual therapy, correct? Orthopedic manual therapy.
Yes,
And
yep.
who did you get your fellowship through?
It started with Evidence in Motion, and at that time they transferred it to Bellin College. So I
Okay.
finished up my last few months or so at Bellin College, and it was funny. One day I get, Southern Arizona, we got great weather. We're not as hot as Phoenix or anything. Often we don't get to 100 degrees, and it was probably like 75 degrees and sunny. It was probably like a March. And I get a message saying that they're going to be closing classes today because of inclement weather, and I just look up and I'm like, I don't think it's too bad where I'm at, but Bellin is in Green Bay, Wisconsin, so it was quite different there.
Yeah. And for anyone wondering, so if you've listened to other podcasts, you will be familiar with Bellin College because Mark Shepard, their program director, he was a guest early on. I think he was episode, I don't know, 3 or 4. So if you like Dr. Rainey's style, you like kind of how he approaches things, and you may be interested in pursuing a fellowship, maybe look into Bellin College as an option, or listen to that podcast to know more about kind of the difference between fellowships and residencies, and if that may be something you'd like to pursue. Um, so, Nick, why don't we'll jump right into it. So this low back exercise, you said that it was a presentation you gave at an APTA conference, which you said it was which conference?
It was the Arizona State Conference. So it was a 4-hour presentation with the state conference. At least how we do it here. There's it was the afternoon track. In the morning there was poster presentations, platform presentations, and then in the afternoon there was like 3 tracks you could go to, and So this is one of the tracks that I got to do.
Okay, so this was a 4-hour presentation.
Yeah, so we won't go down all the details.
Yeah, correct. So I'm just letting you know, for those people listening, we're going to do our best to condense this 4-hour presentation that was given at an APTA conference that you likely didn't attend. Goodness, throat stuck. And we're going to try to condense it down to something that's super useful for you guys in under an hour, maybe 45 minutes. So I guess, Nick, can we start with some principles? Because I feel, without getting too into the weeds, I feel like I'm a PT conspiracy theorist. So, I mean, it's real, man. It's like big research, man. They're coming for us. They want to take away some of the things we do. But when it comes to back pain, I understand that there's a lot of people who will fall back on the concept of a biopsychosocial approach. And I'm not against that. I recognize that. But there are biomedical things that need to be taken into consideration that could be more related to someone's back pain. Like, why do you think, and again, like, you don't have to support it with research. If you can, you're welcome to. If you want to, you're also welcome to. But why do you think, what are big physical causes of low back pain? And the reason I ask that, because everyone wants to say biopsychosocial, it's like physical therapists are not trained in psychosocial. Physical therapists are not social workers. Physical therapists are not psychologists. They are not, like, there are entire specialties dedicated to addressing psychosocial issues. And I think that sometimes we drift too far into that realm instead of being really excellent and pursuing excellence in the bio side of it that we should be able to address. And if you disagree with me, that's fine. So, but like, why do you think that people, like, what are the physical causes of back pain in your opinion? Or kind of what are your views on why people have back pain?
Yeah, that is a big question we could spend a couple hours on to start off.
Right.
And
Right.
And I do address that in the presentation. One thing, difference between like a lecture and mentoring. Mentoring, I can ask, I can address what are your beliefs right now? Where do I need to take you from there? With the presentation, what I did is I had everybody, do a survey, like, what is your background? How do you treat, low back pain? Do you use like a specific McKenzie approach? Is it just a biopsychosocial? Is it you're just treating with pain neuroscience? What is the background that you come with it? So that way I can know where do I need to tailor my my education for on it, because I think that there's benefits to all different types of training and treatment, in the right type of population. So one of the things we hit is like all the different psychological and social issues that can affect low back pain, and there are a lot of them. And what that does is it affects all the pathomechanical or pathoanatomical causes. I am, and so this is where my previous bias is very non-pathoanatomical. My DPT education, decent amount of residency and fellowship, is that don't focus on the tissue. The issue isn't the tissue. Now, and maybe that was just my perception because that's how I got it. I felt like it was originally my PT program.
Mm-hmm.
Then with fellowship, we did get a lot more into nuance of there. What could the tissues be that are causing it? But as I've really delved into the research, tissues are a much bigger deal with pain than what a lot of people are giving it credit for. It's definitely not the only thing, and I realize there's drawbacks to it, and I can go into details about that. But discs can often be painful. Oftentimes they're not, but they often can be painful. And if we look at research by Bryn Jigshee, what he did is in 1 year there was 2 different studies. It was the same research. He published it in 2 different ways, and there was the common chart that we see. This is asymptomatics. Asymptomatics also have these findings. Well, in the same year, same journal, it wasn't open source though, which is one of the reasons why it doesn't get as much pub. Where the other one was open source, but the same year, same journal, same author, it showed that people more often have pain with these findings, and he has a graph of asymptomatics versus symptomatics, and there's a high correlation. with symptomatics. So just really interesting, that we get a narrative and it's easier to latch onto that narrative unless we look at really at the research. It's 10 years old now.
Okay, so can I just write that? How do you spell Brinjixi? I try to get all the research we discuss and I put it in the show notes. Can you at least spell Brinjixi and I can do my own
think
search?
so. BRINJKJE or JI.
BRINJKJE.
E or I at the end.
Okay, I'll find it. I'll find it in case anyone wants to take a peek at it. Okay, so when it comes to physical structures, so let's just stick with that for a minute, because I have a qualm with the PT community as a whole, because we are constantly just bombarded, and I want to get this just out there before we start talking about other things, because I agree with you. We're on this train that is going 100 miles an hour into biopsychosocial, and I think a lot of people are using it as an excuse to not be excellent at evaluating and addressing the tissues. What really just freaking grinds my gears is that we are expected to follow a biopsychosocial model when realistically some of the most revered physicians in the healthcare system are surgeons, particularly orthopedic surgeons, because we deal a lot with them in physical therapy, because they we're dealing with joints and then we rehab those joints. And they are almost exclusively a pathoanatomical model. And everyone freaking says they are the stuff. And it drives me nuts. And so discs are of a particular concern. How often do you think that facets become an issue? Because obviously we know that as degenerative changes happen over time, or someone has an extension injury, we can have stress reactions. We can have I don't see why we can't have low grade sprains of facets going into extension or irritations. How often do you think that other structures of the spine or even other structures around the body are impacting the spine and the pain that it has?
Yeah, so I guess if we take a step back a little bit, as we look at the pathoanatomical model, that's really, so are we using a signs and symptoms approach or a pathoanatomical model? Sure. That's really, so a signs and symptoms approach, I think was made popular by Maitland. And it's what a lot of us as physical therapists use, whether we attribute it to a Jeff Maitland or not, that, hey, I'm going to see how they're moving. What do I find with them? I'm going to treat it, and then I'm going to see if it gets better. Right. And I'm not going to worry about, did I affect the disc? Did I affect the facet? Anything in there. But you're right. Surgeons use a pathoanatomical model. That's what people read about online. And it is strange if a patient hasn't gone and done some research on their own. It is often strange if they haven't gone and gotten some imaging, whether we recommend it or not. It is easy to go to primary care, say, hey, I need to know what's going on in my back. Can I go get an x-ray? An x-ray, and they send them this way. It's an easy screening out. We can talk. They often know. I remember I had a physician sitting in a room with me, because we have family medicine residents that do hours with us. And so she's sitting in a room with somebody that she had referred to me, and they got an imaging that they didn't need. And so normally I'm like, hey, and so I danced that a little bit, right? And after, she's like, I know they didn't need it, but they were requesting it. And it's a difficult conversation to tell somebody, no, you don't need that. The nuance of that can be difficult for us. And this is our specialty. This is not her specialty. And the patient is requesting it. And if you don't give it to them, they probably just call and complain, and then they switch offices. Now as the resident, because she was still doing hours at this other place, she's cost that place business for an uncomfortable conversation, that the patient didn't like, and went and got imaging anyway. Right. So think about that's a high mountain to climb. And so typically they're going to be coming into it with that. So we've got to be able to talk that language. We cannot just say it's a sensitive nervous system, that the alarm went off. We need to be able to talk about what is the disc, what is the facet, and how does that affect your pain? I believe that it does. It's not the only thing, because the problem why we've moved away from that narrative is if the disc or the facet is causing their pain, the only people that can really affect that are surgeons. And so, we're saying, hey, no, we can do that. We need to use a signs and symptoms approach, but be able to talk in a pathoanatomical model. And so that's the thing, the facets cause pain for sure. Typically after discs do. Typically discs are the first thing. They're most easily to injure. But we've got to be able to talk that model and mesh it. If we can't mesh it, well, we can't just say, oh, it's the disc. And that's where the research has been. This is getting on one of my soapboxes here. The research has been like, do we do psychosocial and do we just talk about, pain science, which I'm a big fan of pain neuroscience education. But do we just talk about that, or do we just tell them, hey, this is your disc, that's the jelly donut, it's squirted out, that's why you have pain? And that's been the two different things that have been studied, which is great for initial research. But then what we find is it doesn't really pan out. We're talking to people, they don't really believe us, they're not sure. They go talk to them, oh, guess what? I found out it's a herniated disc. And we're like, well, that's not the only cause of the pain. We need to be able to talk pain neuroscience education, sensitive nervous system, all those things in the environment of this is what is good the disc. This is why you have a good prognosis, because these things do get better. We need to make you one of the asymptomatics, that have this pathology.
Cool. Yep. No, thank you for that. No, I think, if I'm being honest, I think those are the conversations that aren't being had. Because they're hard conversations, and we live in this world of consumerism, and it's like, oh, I read this article, oh, I read this abstract, oh, I watched a reel with so and so for 30 seconds, and it's like boom, 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 and you're just swarmed by information, and in reality, no one wants to be wrong. We all want to be right. We all want to help our patients, and we all want to be right, and we all want them to get better. But it's very like, oh, I'm using the pathoanatomical model. And then Joe Schmo comes with his, other model, and he's like, pain neuroscience education. And maybe he gets a patient or two from us, and he does that and they get better. And then there's some type of threat to us because we've done something, like we missed something, or, X, Y, Z. And I think we need to get past that if we want to address something as complex as back pain. Last question about this. How often do you think that back pain is caused from lower extremity issues?
So that's when I talk about primary pain generating factors and primary impairments.
Okay.
So we are great as physical therapists when the primary pain generator is a little stiffness, and that is the primary impairment as well. So the primary pain, the primary pain generator and the primary impairment are the same thing. So that's the back is a little stiff at L5. We do some type of manual therapy or repeated motion, we stretch it. They walk out of there, they think we're awesome. Well, sometimes the primary impairment may be lower extremity, like lack of hip extension. But that's not, hips don't refer up to the low back, but they can be the primary impairment causing the back to be painful.
Right.
So I remember I come in with a fusion. He's bent forward walking. He walks a quarter of a mile and his back hurts. Well, if I was bent forward, my back would probably hurt after a quarter of a mile, as well. I mean, it's difficult to walk when you're bent forward. And so we're working on hip extension. The hips weren't the generating the pain, but the lack of hip extension was causing the back to generate that pain. It always seems like, and I can't spout off each of the different regions, but like how much do we need to treat the hips for the low back? And depending on how they look at it determines what they find in that research.
Sure.
I believe that we definitely need to be able to treat the back very well, independent of anything in the lower extremities. Typically those, sometimes they're a primary impairment, sometimes it's a secondary impairment. It all goes back, no matter which camp of people that I've studied, different thought processes, you can get the pain a little bit better quickly by treating the side of the pain, by making them move well, no matter how you think that ought to happen, by making them move well throughout the lower extremities or wherever's, if we're talking upper extremities, for neck or whatnot, if you can make them move well, it's going to be a lot easier to keep them out of pain.
Right. No, I agree. So for anyone listening, what we're essentially saying, and I 100% agree with Nick, the back is the source of the pain, or it can be the generator of the pain. It's like, my back hurts because of my back. Like, the pain is from my back, but why exactly is my back hurting? Is it because it's handling too much load because I have poor hip extension? And so, like, we can't just toss physics out of the chat. Like, if they're leaned forward, their body, like the muscles on one side of the spine, are going to have to address that position, and they do it long enough, they may be mad, or a structure may get bothered. Like, what we're saying is, if the lower extremities are not functioning well, and how you get it to function well is your business. But if it's not functioning well, that's something that should also be addressed, to look at kind of precursors to why that generator started going off for their pain. Okay, so Nick, why don't we talk about, and I'm just kind of keeping an eye on our time here. Why don't we talk about the interview process? Because you and I were talking about Jim Meadows' book, and I'll link it for anyone curious. It's Differential Diagnosis in Orthopedic Physical Therapy. And he talks about, like, the importance of the subjective, and in kind of getting an idea of where you're going to go with any biomechanical or hands-on assessment. I guess, could we create some buckets as far as your views on what are the kind of big buckets for addressing back pain that you find most often? Let's just start with that if we could.
Yeah, so as far as the interview goes with it, I am typically a shorter interviewer than I used to be.
Okay.
And I mean, everybody's going to have their biases there. I am much more of a fan of get a little bit of information quickly, start doing some testing, and then I'll ask more questions as I go.
Sure.
Partly that's just how my brain works. I don't want to sit there and ask questions for half an hour and then remember, okay, I need to do this, 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 and this, and then start the objective and then do it. I think, okay, if I'm asking this question, if I'm safe to do that test, I'm going to go do that next. And then it may bring the next question, and I'm going to go with it then. It's just a little more sequential. I know even in my objective exam, I don't focus as much on flow for patient, like let's do everything in standing, then everything in seated, then everything in supine, then everything in prone. It's more about the diagnostic process. What do I need next? I am a diagnostician. And I am most focused on getting that diagnosis as quickly as possible, which also shortens some of my subjective. A lot of the subjective that we get is for prognosis. So the subjective that we get trained for in entry-level physical therapy school all the way up through fellowship training is to give us a good idea of prognosis, and which is really important, because if I just get the diagnosis and I haven't figured out that history, and I blew this early on in fellowship, it's like, I'm going to show them how great I am. Most of us think we're pretty good. And I blew the prognosis. I thought it was going to be like 8 weeks. 100 visits later, she still wasn't better. Normally, I don't treat people that long, but workers' comp just kept sending them back. And you can't say no. Otherwise, the logistical reasons. Anyway, and so that I'm not discounting the importance of that, but typically I'm going to be getting that throughout the end, as I start working through there. And that's a personal preference on that. And so the buckets that I get, I first want to know, is this a flexion intolerant patient, which is very likely a disc issue. Now, is it exclusively a disc issue, or are there end plate issues as well? But end plate issues almost always have some sort of a disc component to it as well, because the disc is in between the end plates there. And so, because if that is the case, we need to be a little slower. It's a more careful management process. So that's what I'm always looking for. Do they have flexion intolerance? Now, some of those are easy, that they're like, oh, I can't tie my shoes or whatnot. But a lot of them are more subtle, and they're not catching it because it's after they've been seated for a while, or they've done a lot of flexion things, and then it's painful later. There's a latent response often with it. And so that's not a clear one. And that's where we have to be doctors. If everything is obvious just by asking a few questions, they probably didn't need us. We are doctors of physical therapy. I need to be able to identify when they're flexion intolerant, when they are not identifying that. So that is a first big bucket. Another one is any type of instability, hypermobility. That could be anywhere from a spondylolisthesis, which is more concerning than just hypermobility. But I'm going to be looking at those somewhat similarly. They just have different prognosis. And I may not know that in the moment. That's where imaging can help inform. So I have my signs and symptoms approach, but pathoanatomy, and this is important, dictates prognosis much more than treatment. It doesn't,
What
it
much more
can
than
direct
what?
treatment, but pathoanatomy, so it affects prognosis much more than what we're going to do.
Okay, got it. You
So a lot of
broke
times
out.
people say, well,
You
I'm going
broke
to do
out.
the same thing. Okay. People say,
Just
I'm
wanted
going
to
to do the same
clarify.
thing. So I don't know why it matters what what the anatomy says. Well, that changes prognosis. So that's where I'm going to look at that instability, hypermobility. Those are not the same, but that's another bucket for me. And then
Sure.
are they just really stiff? Oftentimes that's stenotic, but not often. Or maybe they're just a little bit stiff, but somewhere in that stiffness realm. And some of these can overlap for sure. But those are my three main buckets that I'm looking at as far as mechanical anatomical issues. Obviously, the psychosocial, overlays all of that.
Sure. So in case anyone's wondering, I'll do a quick recap. Three main buckets from Nick. It's flexion intolerance, that from a pathoanatomical side, we're looking more at disc or end plate issues. A literal, like a physical instability, like a spondylolisthesis or any type of pars fracture. And then a third one of stiffness that's often associated with stenosis.
I should add, with the spondy, you can have stable spondies. I don't mind doing manual therapy on a spondy if it's stable. I'm talking about like where they would have positive flexion extension x-rays.
Okay, got it. Okay, perfect. And so I guess what is that little bit of information that you want fast? I think a lot of people, especially young grads, they get in a room with someone, they're like, so tell me about your pain. And you get that one guy that's like, well, in 1997. And you're like, oh no, I don't have the time. It's like, I only have a 30-minute appointment for this. What is that little information that you feel like you need? And how do you get it without making the patient feel like you're not listening?
So I like to stand up early in my subjective. When they say they have
Assert
pain,
yourself.
first, can you stand and show me? What's that?
I said, assert yourself.
Yes. Because so one time, this was in fellowship training, I told the lady, tell me your story. 45 minutes, she's still finishing her cruise story, which is when her pain started. And it was an interesting story. I could glean a lot from it, but you know, it just, I needed to be more assertive. Stand up. Can you show this to me? Now, knee is a little bit harder to make them show you, because they can show it to you while sitting. Low back, they can't sit in a chair and really show you. Stand up, show me. Can I touch you right there? I would need to know where your pain is, because I'll tell you, pain up at like, T12 thoracolumbar junction is different than near that L5, which is different than down near the bottom of the sacrum or the coccyx. And all those people say they have back pain or low back pain. So that's going to change my questioning. And so I say, can I touch it right there? Then that's it. Initially, developing that therapeutic alliance. Can I touch them right there? They know that I know where their pain is. How many people say my doctor never touched me? And even if the doctor figured out, I knew what to do, they have a good idea. They probably didn't need to touch them to figure it out. But I never want my patient to say that. My doctor, my physical therapist, they never even touch me. So I'm going to go, is that it? Yes, that's it. And then when I have questions in the future, and maybe there was a couple different areas, and say, was it that one or this one? So it starts to help me identify, and we're on the same page. So that touching early is super important for that. I forget what the question was. I started going on subjective part
No,
of that.
that's okay. So essentially, and for anyone listening, a lot of us, throughout the day, we sit when we chat with our patients. When I worked with Dr. Rainey, I was specifically with Dr. Todd, and she was awesome. I would sit down, and when you sit down and chat with people, they're like, "Oh, we're gonna have a little conversation," and they're like, and they just start going. It's like as soon as you stand up, they're like, "Oh, we're gonna do something." So if you are sitting in an evaluation and you're like, holy crap, we've got to get going, if you're sitting talking to someone, stand up, and there's a good chance most of the time they will stop talking and either stand up with you or stop talking because they're expecting you to do something. So you're starting off with, where is it? Can I see it? Can I touch it? We're going there. Anything else that you're really like, I guess, what are your kind of key points you want to hit to know how to diagnose?
Yeah, so a lot of times they have some imaging coming in. So that's going to inform me some. The next big
Sure.
thing is age. Age. So in the studies that Mrinjekshi did, it was like less than 50 and after 50. So we
Okay.
talk about, wrinkles on the inside, right? How that we as and I like to talk to people as we have wrinkles on the outside, we're going to have wrinkles on the inside. But if you
Mhm.
have wrinkles on the inside before you have wrinkles on the outside, more than likely that's relevant. So if you start having, some of these things that are associated with age, but you're actually less than 50, more of a chance that's painful. So I like to teach people, and not necessarily patients, but other physical therapists. They say, "Oh, it's wrinkles on the inside." Well, if they don't have wrinkles on the outside, maybe they shouldn't have wrinkles on the inside, and that's more relevant.
Hmm.
So I am looking for some type of flexion intolerance early on. When does this occur? When have you noticed that? And then I'm going to dive down deeper. I do not pepper them with tons of questions. So sometimes we'll be trained to say, okay, what about this? What about this? And we just get a real big run through. Once I'm starting to see if there's any flexion intolerance, I'm going to start running with that. Now, I'm going to remember that there's more that I need, that I could get, that I need to get, but I'm going to start investigating that a little bit. If they don't know, I'm like, what about sitting for a long time? So the other day, somebody's like, I don't really notice when this occurs. She's telling me, and then I'm asking, okay, yeah, I do have a desk job. And after I've been sitting for a while, I start to feel it. She was under 50. She's starting to feel it down her leg. She's been sitting for a while. That's a flexion intolerance to me. What about if you've been doing yard work, pulling things out of the dishwasher, out of the dryer, bending forward for a little bit? Oh, yeah, those times too. So I'm going to ask a few of those key things that most humans do at some point, by bending over a decent amount. If it hurt a lot at the moment, they probably don't do it. It's
Hmm.
after those days I'm getting that pain more so when I've been more active with those type of things. That's when I'm also identifying that flexion intolerance.
Perfect. So, and your flexion intolerance, you're essentially doing active range of motion and standing.
Yeah, so it depends on how intolerant they are, how much I have them do. I will
Sure.
say, okay, what is it? Most of the time, if it's not clear, so if it's clear, they're walking in limping, those, I'm not going to have them do flexion. But if it's unclear, I would say, show me what bending forward looks like. I don't want to, I'm not looking to cause any pain. I just want to see where our baseline is. Because what I don't want to do is assume that it's like 10 degrees and they're putting their palms on the floor.
Right.
And so I want to have an idea, but I want them out of it pretty quickly. I was mentoring somebody the other day, and person bent forward and they stayed there. They're looking at, I'm like, oh, we got to get this person out pretty quick. And it wasn't but a few minutes later, like, oh yeah, it's starting to wrap around into my hip. And I'm like, yeah, we were there too long was the problem. So I
Mhm.
want them out of it pretty quick, and I'm not going to do repeated motions for that. I'm not going to go until they get it, peripheralizing, because that may just bite me. I mean, I don't need to cause pain. They've already told me in the subjective they have a flexion intolerance. I can see that they're not bending forward very well, and so I want to get out of that pretty quick.
Sure. So I guess you really just want to know. Tell me where the pain is, and we're going to start feeling and age. And otherwise, you're kind of starting going. So do you? I know that you don't always do everything all the time, but what are kind of the big things you hit? Because like obviously, so you're going to do some type of active range of motion to see how they move. Unless it's obvious, it's like they walk in or they tell you they're like, I can't move, I can't bend forward. Like sometimes they just very freely offer up that information. What are the other things that you are prioritizing when you look at their presentation of movement, other than like maybe flexion? Like, is side bending important to you? Is extension important to you? Is rotation important to you? Like, or in many ways, does that not really guide your initial treatment direction?
Yeah, so I always do want to look at extension. Is that quickly peripheralizing, centralizing? Very often you're not going to get a quick centralization, if there's radicular symptoms. And we have to remember that directional preference and centralization are two different things. Centralization has a great prognosis. Just directional preference, we're just like, oh, this feels good. That prognosis is just very shaky, is what Mark Warnicki's research has shown. And I've found that to be very true in my own practice. And so I want to see extension. It's like, oh, that's going down my leg pretty quickly. Okay, this is going to be a little bit harder. More likely, there's either a facet issue, it's a really significant disc herniation, or there's a lateral shift. So I'm going to make sure I look at the posture with that. And I don't know if we want to get this to a whole, lateral shift, disc hernia, whole treatment, but I want to know, is there a directional preference? We need to be looking at repeated motions to centralize this. And so I'm gonna play with that a little bit in standing. But before I do that, I will typically, so if we're talking about radicular symptoms, I'm going to be testing myotomes first. Myotomes, I oftentimes don't test dermatomes in the lumbar spine, not necessarily the cervical spine, but the lumbar spine, those line up, the dermatomes and the myotomes. And they're earlier in myotomes, so I'm able to catch things earlier than I am with anything else. So they're more sensitive. And so that way, if there's no myotoma weakness and they're having radicular pain, I know I can push it a little bit more. But if they're like, wow, we're having, so this lady the other day I was telling you about, there was weakness, L3 and L4. So that means when we're doing motion testing, we need to be a little careful with that. We already know that. I mean, we don't have, she's showing us the L3 dermatome. She has pain in L3, she has weakness in L3 myotome. That's not just a psychosocial issue. You shouldn't have fear avoidance inflection. She's already told us it comes on when she's in flexion more. I need to be careful there. Where if there's not that there, then I'm not sure. Maybe it's a fear avoidance issue. Maybe there is a little more psychosocial with it. Maybe it's just irritated. But then I can be careful with, I can dance with that differently than if I know that there's some pathology there.
Okay. So
yeah, I'm going to do myotomes before typically a lot of the range of motion testing.
One sec. My wife is texting me. Got it. So recap. So if you think they can still flex and you'd like to see it, even if they are flexion intolerant, it'd be good to look at and see what happens to their symptoms. Be aware, though, that if they're particularly sensitive and you leave them there too long, you may set them off. And you always want to look at extension. If one of those feels better, that identifies a directional preference. Is that correct?
Yes.
Okay. And from there, if there is not a directional preference with their symptoms, that either back feels good or forward feels good, are you testing myotomes only if there's radicular symptoms, like if there's symptoms in the leg, or do you test the myotomes every time and just use it as like manual muscle testing for major muscle groups?
I don't really ever use it as manual muscle testing for major muscle groups. I'll do that separately.
Okay.
I will do it every time there's any symptoms below the gluteal fold.
Okay.
Or if the patient is thinking they need imaging and they don't have it yet. So if I need to reassure them, hey, I think this is a disc issue, I'm going to do that because then I can assure them I've looked at it. Hey, remember, I wanted to see, are your nerves functioning well? I know that we're not going to pinch a nerve there. Use their language. Okay, good. Because that's what, if I don't address that specifically, they think they have a disc issue. They know somebody else had a pinched nerve, ended up in a wheelchair, had surgery. Hey, I know that the disc may be a little irritated here, but it's not to a point where it's affecting any nerves. So I'm very optimistic. That's a good sign. That's a good prognostic sign for you. So then I have a reason to tell them that, not just because I think I'm so smart. I did this, and this is why I'm making that recommendation for you.
Great. So what are you looking? So that seems to make a lot of sense to determine if someone is like flexion intolerant. What are you looking at to put them in the bucket of instability?
So there's a number of different tests we can do. I like to feel their back next. Get them on their stomach. I want to feel their back. Partly there's that therapeutic alliance. They came in with a back problem. I'm going to feel their back. I spend time with it. That way, whatever recommendation I give, they believe me. Hey, when backs feel like this, they do really well with this. I'm fully aware that a lot of times I'm going to give them the same thing that I would have given them had I not done that. Other times that it changes it, sure. And it does change my prognosis a little bit with what I feel. But when I touch their back, they do their home exercise. We talk about what the research shows, it's the same sometimes. Well, sure, but we don't have the benefit of the Hawthorne effect, in practice. In research, if you know this person's doing a research, we need to see which treatment is more beneficial. Like, hey, they're looking at me. These must be really good physical. I need to make sure I do what they asked me to do, so that way the research, can show what it's supposed to show. I don't have that effect. They can just not believe me and go somewhere else or not do it and come back. I need to touch their back, and so I can say, hey, when backs are like this, they do really well with this. And so then they believe me because I've touched their back. Also, what that does for me is, how mobile is it? That's where there's a lot of different instability tests that can be done. Mostly, I'm going to be doing accessory mobility on their stomach. Is this, feel more mobile than I'm used to, or less mobile? How painful is it? And I'm not looking. One of the critiques of manual therapy and accessory motion testing is like, is this a 3++? Is this a 3-? And they're just getting really into the nuance. There can be benefit with that with some people, but the vast majority of the time, does this feel like, somebody who has EDS with hypermobility, or does this feel like somebody whose back is like a rock? That's going to be a different treatment. That's going to look just a little bit different. And sometimes I can work on it a little bit, and they can come out there feeling a lot better. Was that mechanical? Was that, just because I touched them? Very likely a little bit of both. But I'm going to do a little bit of accessory motion testing very early with them. And if it's pretty mobile, I'm going to know that I don't need to be doing a lot of, I don't need to be working on mobility there. It's going to be more exercise based.
Right. So are you primarily talking about PA mobilizations in prone?
Yes. And typically just unilateral. I rarely will do central now unless they're just really stiff and I'm trying to, and I'm really working on the stiffness there, but that's not very common. Typically I'm doing unilateral to see if it's different side to side. Again, that can help shrink the homunculus. If they're, sharpen the homunculus there. If I'm going right, left, they start to be able to get a little bit more lateral differentiation there. What is it right? Right, left, higher, low. And so that there's just a lot of components to that that's helpful for me and helpful for them.
Sure. So is that, obviously, like you said, if there's a true instability, like you'll see it on imaging. But if someone feels like, you push on their back and you're like, ugh, like either that segment or the spine as a whole or a portion of the spine is particularly mobile, you are kind of leaning towards the bucket of instability, even if they are already flexion intolerant.
Yeah, and so they could definitely have both there. It would be pretty difficult to say, yeah, there's a unstable spondylolisthesis with PAs. More than likely, it's just painful. Now, is that a disc issue, or is that an unstable spondy, or are they just hypermobile?
Sure.
In the end, I don't really care for initial treatment. It can affect prognosis, but I'm probably not going to go at imaging just for prognosis. If they have it, I'm going to use it. Why not use what they already have?
Right.
But I'm going to, again, we do imaging, we do any test, imaging included, if it's going to change what we're going to do. I don't get it just if it's going to change their prognosis. I do it if we're going to change what we're going to do. I typically err on it's likely a disc issue because that's the one that's easiest to flare up. I may be able to not restrict flexion and they may do all right. But if I don't, and it is a disc issue and the data says that's most likely, then I'm going to treat it as a disc issue, even though I know in my mind, I'm not 100% sure it's that. But if I'm going to be doing the same thing, I'm not going to go get further testing. And so that's why I err on that most often, even if I know that there's a chance it could be something else. Because even if it is an unstable spondy, does that mean we're going to just do a surgery immediately? Or are we going to see if we don't go to end ranges, we do some exercise in mid-range, we give it time to heal, and it can scar down. There's a lot of spondylolistheses that are not painful and that are asymptomatic. So that means that maybe at one point it was symptomatic. Let's see if we can take the symptomatic one to be asymptomatic. Even if I'm not sure that it's, I'm not sure that it's there, but I'm going to limit their motion like I would if it was flexion intolerant.
Sure. And so what about stiffness? And then we'll jump right into exercise and kind of where you're going with that. Like, is stiffness just going to be like, oh man, I just feel stiff forwards, I feel stiff sideways, and the other side and backwards, and you push on their back, and it may be a little more hypomobile with like joint mobility. Like, is that essentially what you're looking at to determine if it's stiffness, or is it more that it simply isn't the other two, and so it's most likely stiffness?
Yeah, I don't really care if they think they feel stiff, because you get
Hmm.
people that are hypermobile that feel stiff. They're like, oh,
Right.
I know I need to stretch more. I know I need to stretch more. And then they stand up, they bend forward for, chest out flexion, they put their palms on the ground. The stiffness ain't your problem. You know what I
Yeah.
mean? Like, we don't just need to keep stretching. They feel that stretching, because most people, they feel pain, they relate it to stiffness. That is
Hmm.
a common thing among physical therapists, massage therapists, healthcare providers in general, the lay public. If you feel pain, it must be stiff. So they feel some pain. And how many people like, oh, do you think you could show them a stretch or something for their pain? Is there a stretch you could do for this? We have very poor research that says stretching can do anything for pain. There's a few small cases that it can.
Sure.
But so they're thinking that it needs to stretch. So I don't really care if they say it feels stiff. I get people with EDS that say they feel stiff. But if they're not getting much motion with when I'm testing range of motion, and then when I'm assessing accessory mobility, if it's pretty stiff. Now, that said, that is not the sole cause. There's a lot of super stiff people that don't have pain.
Right.
And and so if you treat the stiffness, what I do find, if I treat the stiffness with somebody that has pain, the pain gets better. The stiffness gets maybe a little better. The pain
Mhm.
gets a lot better. And so if you treat somebody that is stiff and painful, and you treat it as stiffness, typically the pain gets quite a bit better. And that's not the only thing we need to do. That's that, again, we can get them better quickly, and then there's all the other things we need to work on to make them moving well and everything.
Okay, cool. So, um, let's talk exercise. It looks like we got about 10 or 15 more minutes. And, quick recap, guys, from Dr. Rainey's evaluation process, if I can and he'll give me a thumbs up or not. Like, realistically, they are coming to you. Like, physical therapy is not talk therapy. You should expect to get hands-on with your patients, to feel the areas that they're like, hey, this hurts. And you can get a lot of patient buy-in and build a good rapport by touching the area that they have been telling people is bothering them for any number of weeks leading up to them coming into your clinic. And it may be, the people that are like, oh, you don't need to touch them. You may feel something and be like, well, okay, that's different. But realistically, get as much get a little information about where it is, any other major red flags that you are, comfortable getting, and then start working on them. It looks like a good place to start with low back pain is, if they can, look at some range of motion, bend forward, see how that is, see if they have increasing radicular symptoms, do some extensions, see if they have a movement preference. And whether they do or not, it's a good idea to get them on their stomach, feel the spine, see how it feels. And for the people out there that are like, physical therapists can't tell the difference between stiff and non-stiff. Bull. You feel 100 spines, you will start feeling that some feel different than others. Now, you will have to determine how relevant that is, but feel the spine. Give it a push, check the joint mobility, see how it moves. And determine one of Nick's 3 buckets is flexion intolerance, instability, and stiffness. And looks like we're going to go from there. So
Hey, Nate,
yes.
can I make a comment on how much we can tell on that?
Yes.
So there was an article. I won't say the author's names because I was critical of it, but they said that research shows that we can't identify it. And so I'm looking through. I was like, okay, what do they do? Like, why do I feel like I can and they can't? So I'm looking at the details. And they say the experienced manual therapists of the authors on there, and they gave the initials. So I went back up there, looked at the initials. I looked up the CV, and she'd done part-time practice over 20 years ago. That was their experienced manual therapist. I'm like, so I felt more low backs this week than you have in the last 2 decades. And she might have done some Con Ed course. They're the respected manual therapists in their research group at the university. But that's just not, you can't tell me that somebody who's hasn't felt as many backs in 2 decades as I have in the last week, that's apples and oranges.
Right.
The other problem is what they do is they line people up. These are not real patients. This is an academic setting, and they, it's between me and you, and see if we agree. Well, we may not agree. That's what's going to happen there, is that we're not working with the patient to identify, is that relevant to you, and is that a significant enough difference? So one time I had a patient. This was actually a neck pain patient, but I had two students that were with me. I said, okay, this is the first time we'd seen the patient. I'm going to feel the neck. Then each of you are going to feel the neck, and we're going to see if we agree. I felt it, and I was like, this is kind of a funny one. I don't think there's anything relevant here. Maybe a little difference here, but I didn't think it was relevant. In a research study, we would have to use that person, to see if we agree, and then it would have shown that none the three of us didn't agree. Now they could say, well, those two are students, they're not as good as the expert. There wasn't anything relevant. So they each told me what they felt, and they were different. I'm like, yeah, I don't think there's anything relevant there. In research, you have to make something up and to see if you agree. You can't just say we're going to toss out that subject, because it's hard enough to recruit subjects. In real clinic, I can just say, nothing significant there. And so that's where some of the difference is. Can we tell? If there's something significant, we can tell. Sometimes there's not things significant, and we don't have to force it like you may have to do in a research setting.
Right. No, thank you for that. I appreciate that, Nick. Like, yeah, we won't get into that because we're going to talk about some exercise, because we could both get on a soapbox for a while there. So I guess I'll say this first off. We are entering this weird Instagram social media person where they're like, flex that spine. The spine is strong. Like, you're good to go. Like, don't let those pencil neck physical therapists tell you that you shouldn't lift. And that drives me nuts, because there are times when you should, like, it's not that you shouldn't flex your spine. The spine is meant to bend, but you may need to offload it so that it can heal and it can become less sensitive, so that then you can address flexion from a point of strength that your body will adapt to, accept, and make you more functional as a person. I will say that first off. But Nick, why don't address it however you want? I will just give you the floor. We've talked about buckets. We've talked about assessment. Why don't you just kind of riff as long as you like about low back pain, and we'll kind of plan on ending in less than 15 minutes.
All right. Well, if I don't hit something, make sure to let me know.
I will.
If one of the things that I've done, and it bothers me when other people do it as well, they hang their hat. So they're going to have a major aspect of their treatment based on research that they don't really understand. So let me give an example. Back in 2005, Kumanikis and colleagues did research on specific exercise versus general exercise. And the purpose of it was, do I need to be really focusing on transverse abdominis and multifidi, cueing? So I need to cue the patient for that, and they need to be trying to do that. That was the purpose of it was a well-done study. I didn't look at the details enough. So this is not a shot at them. This is a shot at me. And so the outcome was general exercise is just as good, if not better, than specific exercise. If you look at the pictures, which I didn't do for over 15 years after the research came out, the pictures looked exactly the same. I basically went off the gist of it. The difference was, are you cueing the transverse abdominis and the multifidi, which people should not be cueing those. People should not cue transverse abdominis and multifidi. We don't have good research, and this is one of those that refutes doing that. I took it to mean, do I need, that what I just took from the conclusion of it was, do I need to be doing real specific, or do I just need to get them in the gym? Can't go wrong getting strong. Mm-hmm. And we kind of are back and forth. Do we do the transverse multifidi and, really specific cueing, or do we just can't go wrong getting strong? And most people end up kind of in between there because they don't really know, or they're going to be going in one of those camps. Well, the truth lies much more in between. The group that did general exercise was doing bird dogs. They were doing bridges. They were doing side planks. They were doing a lot of good exercise. They just weren't cueing the specifics. And why didn't those people do as well? Maybe because they progressed them more slowly. Maybe because they're making them kinesiophobic. Maybe because they're like, oh, you're still not getting it. The person is like, oh, if I don't make sure I contract my transverse abdominis, I'm not doing as well. I don't know why that group didn't do as well. The results weren't that much different. But they did err on the side of just the general exercise, which didn't include deadlifts or squats or bench press or, things that you would think of just general exercise going to a gym. Another area where we also, now this research was well done, it's the application where people mess up on, is that what they did is they brought in 3 different types of groups in there to be able to lift weight. I'm hoping I'm getting all the details of this study on there. But what they did is they looked at there to see how they lifted the weight. Did it correlate with low back pain? So if I have somebody come in, do I make sure that, do they lift carefully or do they not lift carefully? Because that would indicate how do they do it in general life. And then which group is more likely to have low back pain? Well, what they didn't do is when they had them lift that weight, it was right about 25 pounds.
Mm-hmm.
Well, I'll tell you what, lifting 25 pounds and lifting 100 pounds are 2 different things, or 200 pounds is 2 different things. And so then we extrapolate, it doesn't matter if you flex, and don't worry about keeping a flat back when we go deadlifting at the gym. That's not what the research looked at. So you've got to know the details of the research. And if you're going to hang your hat on something like, it doesn't matter if you flex, when there's a lot of people that feel flexion as could be problems, we have a lot of data that says flexion can herniate discs and cause damage. If you're going to hang your hat that it doesn't matter, you better know the details of the research and know that it applies to your patient situation. The purpose of the research is to make it so that we don't tell everybody every time they go to pick up their shoe, every time they go to pick up their baby, that they have to be real careful, that they have to make sure that they hip hinge no matter what, or they're going to have a herniation. Because that's not accurate. We don't have to be perfect lifting every time we lift anything. But if we're going to be doing it a lot, if we're going to be doing it fast, or we're going to be doing it heavy, we don't have research saying that it doesn't matter. And so before you're going to tell people it doesn't matter, you need to know the details of the research. And then you need to know how it applies to the person in front of you. Is walking a bad thing? No. If you just broke your ankle, walking is a bad thing. Don't just say, oh, it'll get better. Just walk it off. No, we need to ease off for a little bit. But it's easy to see a fracture. And nobody says a fracture doesn't cause pain, in their ankle. We know that hurts and it needs to be offloaded. You can have damage in your back. And we don't just need to say, well, I don't know which one is causing the pain. Well, just because you don't know doesn't mean that nothing is. So you've got to know the details of the research before you hang your practice on research that you don't understand. That's my biggest message there. What questions do you have from that? What sticks out there?
No, what a soundbite! What a soundbite! I like it. I guess I guess this is a clarification for me. Are we talking about exercise principles in general, or did you want to talk about specific exercises for different buckets? Because I know we're kind of coming up right on time.
Yeah, I can do that.
Because like I said, so for anyone listening, Nick and I, we were chatting before this. He's got to get to his son's soccer game, and we're gonna make sure that happens. Because if we were the kids, I love my podcast. I don't want my dad missing my soccer game to be on my podcast. So, Nick, why don't we do this? If you would like to talk about some specific exercises, that's fine. But also, I think what you just said was fantastic because it'll give people a lot to think about. And I'll reach out to you afterwards to get the names of those articles so people can see that you're telling the truth about those various articles. Would you like to talk about some specific exercises for a few minutes, as safe places to start so people can kind of know your style and then wrap up?
Yeah, I could give a couple principles and then a few exercises there that follow those principles.
And then we'll call it.
So the principles is I don't want the spine to move while I'm doing exercise. Now, I don't believe that every time it does that they're bound to have an immediate herniation or whatnot. But the data shows, and there's lots of data, so we have to look at a number of different types of research, because what we can't do is say, Nate, you do 1,000 sit-ups every day, and I'm not going to do, and see who has more problems in a year, 5 years, 10 years. We can't do that research. So we have to look at mechanistic research. We have to look at occupational epidemiological research, to really be able to get that in the mechanics research. But so I don't want the spine to move. So here are three exercises that I quite like. I like bird dogs, I like side planks, and I like planks. They're pretty easy to teach. The spine isn't moving, and the compression that I'm getting is from the muscles, not from gravity. So the muscles are compressing. So I'm getting some compression. Compression isn't bad. We just need to know, it's all in context. We've got to do it for the right person, and we want to be able to limit any other strenuous factors. That way we can get as much muscular work as we can. And so those are three exercises I like, because what I want to do is I want to be able to have, I don't want the spine moving. And if we get flexing and we get twisting, those are problems. So some, I'll take sit-ups away from people. The gym machine where they sit, they go like that. Those people are seated. And when you're seated, no matter already, even if you're trying to sit up right, L5S1 is already at 60% flexion. So then you're bending forward with the muscles compressing. Now, is that an immediate problem? No, but I've taken that away from people. I remember one lady, she always had a problem after she was at the gym. I said, do you do that exercise? She said, yes. When she got up from the gym, she didn't have her ridiculous symptoms anymore. All we had to do is take away that one exercise. The rectus abdominis is a pretty simple muscle. It flexes us, but it provides a flexion moment. So if we do planks, we can really hammer that. If people say planks are too easy, I say just walk out your arms. There's ways to increase it without just adding weight, and adding motion. So if we can keep people from moving their spines during core training, we're going to be able to get a lot of benefit with people. And I do that almost no matter what their low back pain problem is. I mean, there's always, nuanced differences and depending on what their primary problem is. But I'm going to be doing that for a lot of the buckets. It's going to depend on how much I do it and when I start it, really.
Great. And did you say you had more than one principle, or was that the primary principle?
That's the simplest. That's the primary principle. We'll stick with that.
Okay, got it. Well, Nick, thank you so much for your time. Like we'll call an end to that. I think this will give people a lot of stuff to talk about. And if we want to do a part 2 or we want to discuss anything else in the future, we can of course do that. Nick, you're welcome to end saying whatever you would like. And a big thing people are often interested in are people. A thing people are often interested in is what is kind of your favorite maybe book you've read on therapy or course you've taken, and as well as where do you regularly get information to help you continue learning, and then just wrap up however you'd like.
So fellowship training was obviously most influential for me. Everything that I do is based off of that. So it gives me a framework to think. And I'm different than I was 5-6 years ago or whenever, when I graduated that. I've continued to progress and I've added like pelvic health training and oral facial pain training. I've gotten even more specifics in low back, but it all goes back to that framework of thinking. So the biggest thing I can recommend to people is long track training. You need to be able to a standard process to think, so that way you have a good root system, a good base that everything can branch into. If I'd just done, a bunch of different buckets, it's pretty difficult to make those all mesh. Where now I know no matter what I can study, I can bring it back into my framework of thinking that is patient-centered and evidence-supported. As far as how I stay up to date now, I write down how I'm going to get deliberate practice. I don't want it to just be random. So when I get emails, I put them into a folder. So no matter if I have a 5 or 10 minute break, I can go to that folder and I can quickly pull up an article to read. I make sure that I also, I want to make sure I hit this. I'm going to listen to these podcasts. I'm going to watch these videos. And then I identify where my holes are at. So what I do each year is I write down where my weaknesses as a physical therapist. Where am I know that when I'm with a patient, I'm just not quite as good as I think that I could be. This person isn't getting better and it's partly my fault. And I'm going to write those things down. So that way the next year I can address those. And I'm thinking that when I look back, I addressed this, but I haven't addressed this yet. How am I going to do that this year? If it's just haphazard and we take whatever looks interesting, it's not systematic enough. So I want to make sure I'm addressing my weaknesses systematically. And that's the biggest recommendation I have. Make sure that you have it planned what you're going to do and make sure that you're addressing that easily. If it's difficult to go pull something up to read or difficult to learn, it's not going to happen because we all have a lot of things going on in our lives. and we tend to spend it on important, urgent things. And studying is rarely important and urgent. It's important and not urgent. So we have to make sure we schedule it in.
Okay. Thank you so much. So anyone, if anyone's interested, Nick teaches, right? You're still doing the course, the TMJ course?
Yep, I do an online TMJ course. Actually, this fall we're going to do I'm pretty excited about this. It's going to be a 4-day low back course here, where we're going to hike mountains. We're going to go on tours. We're going to get to network, with physical therapists, from around the country. We're going to spend 4 days together doing some fun things, but also learning full management of the lumbar spine here at our clinic. And we're going to get, real patient experiences with it. It's going to be a lot of fun.
Okay, excellent. So you're doing your 4-day tour. Are you still doing that mentoring with the Brainery, Movement Brainery?
Yes, I'm still a mentor on the Movement Brainery. I think you can find most of my stuff at our Rainey Pain and Performance website under careers or opportunities, something that looks like it's geared for physical therapists. I forget what it's titled now.
Got it. So all that really means, guys, if any of you guys are interested in interacting with Dr. Rainey, having him as a mentor, being a part of the groups that he's associated with, I'll make sure to include those in the links in the show notes.
Yeah, please. Thank you.
No, absolutely, Nick. You have been a blessing on my life. You're a good guy, and there are very few people that I revere as highly as you. So I'm very appreciative to have you on the podcast.
Oh, you're too nice, Nate.
Okay. Thanks, everybody.